Falls Area Chamber of Commerce. I want to thank you for joining us for this COVID virtual town hall, talking a bit more about COVID vaccine that's available in our community and recent changes to the upcoming groups who have eligibility for vaccine. Again, thanks for being with us today. We have two presenters today, Dr. Joshua Kern, who's the Vice President of Medical Affairs with St. Luke's, Magic Valley, Jerome, and Wood River, and Logan Hudson, Public Health Division Administrator for South Central Public Health District. Thank you to you gentlemen for joining us today. So the way this is going to work, if you didn't participate in our last one, we'll go through the ground rules here real quick. So at any time, you can type your questions that you may have into the chat window. I'll track those questions and summarize them for our panelists to answer as we go along. We would please encourage you to use respectful speech. Our goal is to share ideas and information with as many folks as we can, but this is a limited public forum. And again, just use your good neighbor skills as you're posing your questions today. On the agenda, we'll have a quick update kind of on the status of COVID-19 in our region and in Idaho. We'll talk some about the vaccine science and effectiveness, including the new Johnson & Johnson vaccine that is starting to become more available. We'll visit about vaccine distribution status in our region and the current vaccine eligibility, and then talk a bit more about planning for future vaccine eligibility for upcoming groups who are anticipated to have eligibility starting next Monday. And again, the conversation will be better with good questions from all of you. And at the end, we'll wrap up with some COVID information resources. So with that, I'm going to turn the time over first to Dr. Joshua Kern with St. Luke's to give us an update on the things that are in his purview. Dr. Kern.
Yeah, I was thinking I would talk at a high level about the different types of the vaccines. And I covered that last time, so I'll be a little bit duplicative from our previous one, but I'll try to maybe even be a little bit briefer. And again, talk as much about the Johnson & Johnson vaccine, which has been approved by the FDA. So from a technology standpoint, the mRNA vaccines that we now have for COVID are the Pfizer and Moderna. And what essentially the way those two vaccines work is there is a piece of messenger RNA, which is essentially wrapped in a lipid layer. And it's that lipid layer that helps it get into your cells where it's injected. Those cells then use their protein machinery to make a small piece of the virus. It's specifically the spike protein that is on the surface of the coronavirus. That piece of protein then is released into your bloodstream, and your body then recognizes that as foreign and starts to make an antibody response to that. We've seen now tens of millions of those doses given out in the United States. It's been very well tolerated. The mounting evidence is that it is working incredibly well. It is actually seems to be protective against the variants that we're hearing about. That's the initial kind of data that we have right now. So very encouraging results. As everybody knows, each of them does take 2 shots 3 to 4 weeks apart, and then you're not really considered immune to the virus until 2 weeks after your second shot. The Johnson & Johnson vaccine, I'll speak briefly about a couple of questions we got via email about the mRNA technology. One, we got a question, something to the effect of, I heard, I'm paraphrasing what the person said. I heard that the mRNA vaccine can kick cancer into high gear if you get the shot. There is not really reason to believe that. There has not been any evidence of it impacting cancer or making cancer become uncontrolled or something. And in fact, the mRNA vaccine technology has been being used to treat certain types of cancer. My actually good friend from medical school is doing a huge study out of the University of Washington on metastatic melanoma and the use of this same technology, mRNA, to essentially vaccinate you against the cancer that you have. So that is, again, a piece of this mRNA technology is being used for other things. This isn't totally new to the vaccine world. And so now I'll pivot to the Johnson & Johnson vaccine, which is a different technology. This is actually a DNA based vaccine. It has a inactivated virus that then has a piece of that same piece of DNA. So it's a piece of DNA from the coronavirus that encodes for the spike protein. And the inactivated virus then is able to inject that piece of DNA into the cytoplasm of the cell, which then the same mechanisms happen. The DNA turns it into messenger RNA, and then the messenger RNA turns it into protein, and then all of that mRNA and DNA gets broken down and isn't really left behind. And then again, same thing happens. You get an immune response to that spike protein. We're seeing that the Johnson & Johnson vaccine, which has one shot, seems to be working very well at preventing severe disease. It's maybe not as effective as the RNA vaccines when it comes to preventing any disease, but what they've seen in these studies is that people who get the Johnson & Johnson shot, essentially none of them die, none of them get hospitalized, and it's preventing that sort of severe disease, but you might end up getting sort of mildly sick if you get exposed to the coronavirus. Interestingly, also in the Johnson & Johnson study, it was shown to prevent spread of the virus. So if you had the vaccine, you were less likely to be able to spread the virus, which had not been really studied with the studies around the mRNA vaccines. So that's kind of high level. I don't want to get too much into the science. Beyond that, it starts to get kind of confusing. I will talk about one of the other email questions just kind of preemptively because we had them. And there was a question about whether or not fetal cells were used in the development of these two vaccines. And that is a very complicated question. And the reason that's complicated is that there are many cell lines that are used in science that are developed from fetal cell lines from like the 70s that are very special cells that have continued to be used for science for decades. And I believe that some of these, what are called immortal cell lines that did come from originally fetal DNA, or fetal cells, were used in the development of these. The Catholic Church, which has pretty strict guardrails around those types of issues, has actually come out on a world scale and said, basically the Pope has said, you should get the vaccine. It is moral to use those immortal cell lines to do research to prevent disease and develop vaccines. So for what it's worth, it is a maybe more complicated question than were fetal cells used or not. Those cell lines have been being used for a long period of time, and where and when they were developed is very, very complicated. So that's what I was going to share. Martin is asking in the chat, can you tell us what all the ingredients are? I actually cannot tell you what all the ingredients are, only because I haven't been asked that question. I have not researched it. Again, I know that the mRNA vaccines have a stabilizing molecule called polyethylene glycol, which is a very commonly used molecule. In fact, people take it, ingest it freely in the form of a medication called Miralax for constipation. And that is one of the things that has been thought to cause some of the low rate of allergy to the mRNA vaccines. So there's that polyethylene glycol, and then really it's just a lipid layer and that piece of mRNA. I don't think there's a ton of other ingredients because the polyethylene glycol is the stabilizing agent for the mRNA vaccines. And then as far as the stabilizing agents in the DNA vaccine, I'm not actually sure about that. I could, while Logan talks, I will try to get an answer for that because I'm proficient at looking things up.
Great. Thank you, Dr. Kern. I just want to note to everybody, there were a couple of comments about folks who weren't able to attend the first webinar that we did back in February. So I did post a link to the YouTube recording of that that's on South Central Public Health YouTube page. So if folks do want to go back and watch that from February, you're welcome to. We'll jump over to Logan now. And maybe Logan, can you just kind of touch briefly on sort of what's the feel of the current status of COVID-19 infection in the region here?
Yeah, so that's actually a good place to start. So my name's Logan, and I'm with South Central Public Health. And for almost 1 year now, we have dealt with COVID in our region. I think we're coming up on a year on Saturday. So that was when our first case was reported. And we've had ups and downs and spikes and valleys, with their most recent spike being in October, November, December, and kind of this really quick drop off after Christmas and New Year's, which we were a little bit surprised to see, but also very grateful that it stayed and it wasn't just a sort of a mirage of people not getting tested or things like that. But really more recently in the last couple of weeks, we've seen numbers that I don't know if we ever thought we would see again until everyone is vaccinated. And we're looking at numbers down, around less than 1 per 10,000 people as a rolling average, 14-day rolling average in some of our counties, which is just amazing. Those numbers from the CDC standpoint and from the state standpoint kind of put us in our region at in the category of minimal risk. I don't want people to think that, it's minimal risk, we can just go do whatever. We still are encouraging mask wearing. We're still encouraging social distancing because we do know that there's still a huge chunk of the population who's probably not immune. There's 20-some thousand people in our district that had confirmed or probable cases. There's probably another 20,000 or so, maybe more, that had COVID and never went and got tested or weren't identified as a probable case. And then there's 20-some thousand now that have the vaccine, and some of those are going to overlap and this and that. But so we do know that there's some immunity. We also know that there's probably some herd immunity within certain populations. So some long-term care facilities, the population of people who weren't ever going to slow down, kept going out, they probably have some herd immunity because they all got it early and there. But there's also a lot of people that have stayed home through this whole thing and been really careful and haven't had the vaccine yet. And so I think that's what I'm kind of saying. It's still important we protect those people by doing the right thing, by wearing masks, avoiding large gatherings, and at least for a few more weeks, a few more months till we can see what this thing does and we can get more people with vaccines. I'm very optimistic that if numbers keep going, that summer will feel a lot more normal than we've ever felt or what it's felt like in the last year. But I just want to caution people not to jump ahead too fast and next thing you know, we're back to where we were, or at least crawling up again and having to really slow things down. So it's kind of where we're at. We're also seeing a really low positivity rate in our region, which is another good sign. That means people are still testing, but the tests themselves are coming back negative. And that kind of tells us that maybe the disease isn't here as much as we've seen. And just kind of to put it in perspective, when we saw our spike in October and November, we were seeing positivity rates in some of the counties as high as 20%. And last week, some of our rates were less than 3%. So it's a really good sign, and we hope it continues. And I know Dr. Kern and all the staff at the hospital and public health staff and all the business owners are just keeping their fingers crossed that this is the downhill slide we've been waiting for. And part of that, like I mentioned, is because of vaccines. It's because we have vaccines getting in arms. We have people in our communities that are fully vaccinated or partially immune, even with one dose. And the vaccine train ride is continuing to go up and down, up and down. Last week, the governor's office pushed up the, I'm going to call it the Ag and Manufacturing Group, to March 15th, which we as a district we're always really preparing for April 1st. We know we still have quite a few seniors actually to get through, but we also knew that some providers in some counties might start having some appointments to fill. And so it didn't bother us that much that this group got to go a little bit sooner, because we felt like we could start trickling a few people into some providers and getting out. The big change, though, came yesterday when they also added the first levels of Group 3. So we've done Group 1, Group 2, and now 3.1. And we heard about it when the rest of the state did, that they were going to sort of stratify this group by age. And every week, I think, a new age group or a new group with or without a medical condition is going to open up. So by the end of by Easter, first weekend of April, anyone 45 and older in Idaho will be able to get on a list to get a vaccine. Where this becomes a challenge from a vaccine standpoint is we still have a limited amount of doses that are coming to our state and then getting pushed out to the health districts. There are much more people in these groups than we get doses per week. And when we sort of finish a group, we were expecting there to be a little bit of I don't want to say a slowdown, but empty slots starting to show with the 65 group, and we'd start filling those with the next group. But now that they've opened pretty much anyone 45 and older in the next couple weeks, I don't think we're going to see any type of lull in, we're ready to move to the next group. It's the demand from all the providers is going to remain very high, or in all the areas for the providers to provide vaccine, I should say, is going to remain very high. Where this becomes a challenge with the people on this call, I assume most are business folks, is we have to, as a collection of providers, have to figure out how to fit everybody together now. We're not just focused on one group at a time as we were with the 65 plus and the healthcare providers before that. Now we have these business people, manufacturer ag, plus this 45 and over crowd that may not fit in there. And there will be a lot of overlap, and we know that our main industry here is ag and manufacturing. So we know that there'll be some overlap, but we're also going to get a lot of people in that group that aren't tied to those that want the vaccine. And we're working through that. Again, we just found out about this yesterday. We are still prioritizing our 65 plus, and we're still going to work with the manufacturers and the larger plants and some of the ag folks to get out, and either us get out and do vaccine in their facilities, or partner them with another pharmacy or another provider such as St. Luke's to go and help them out and get them vaccinated. We're definitely not going to leave anybody by the side of the road just because the state opened this other group. The reason for the state opening this other group is because there are health districts that did say they don't have that many people in the ag and manufacturing group, and that does make sense for some of the counties that are in the state, and they wanted more, and the state felt it was better to do it statewide and not county by county. So that's kind of where we sit. right now, and we are, we're just getting vaccines every week, and we're getting them out to providers and into our clinics as fast as we can and getting them out. We're expecting a huge jump in vaccine supply over the next couple weeks. Predictions are somewhere around 80% more into the state, that's a lot. That's almost double. That will change things greatly in our region, and a lot of these providers that aren't able to do full capacity vaccine clinics may just be able to jump up and do that. As far as the other new thing, the statewide wait list, this was another thing that we learned about, I think, last Tuesday, and it went live Friday. And I'll be the first one to say I was skeptical, and I still am a little bit, but and there are some flaws, and the state's aware of these flaws, and they are trying to fix them. But this is where the state wants people to go, and we are encouraging people to go sign up. Every provider that's signed up to give COVID vaccine has access to this wait list. Therefore, if you're on it and a provider is looking for people, your name can get pulled into that provider's queue for them to call and get you a vaccine. Any employee is encouraged to get on. Even if we're coming, or somebody said they're coming to your plant, you can still encourage your employees to get on, because somebody may be able to get it to them sooner if they have an appointment available. Again, there are some flaws, and the state knows about them, and we continue to point those out to them, that what's working and what's not. But I think it will ultimately help people feel like their name is out there, so somebody can find them if they want a vaccine. And I think that's all I have. If you guys have any questions, I'd be happy to help answer them.
So one question that came up in the chat there that I think you could answer: is the Johnson & Johnson vaccine available here now?
Yes, we, as a health district, and I just from last time, if you'll recall, we serve 8 southern Idaho counties. So, kind of, if you think about Magicville, Wood River Valley, that's where we're at. Last week we received 1,500 Johnson & Johnson doses. We distributed those out equitably by county population to the counties. So everybody got a little bit based on their county population. We were told we wouldn't get any more this week or next week, and are expecting some that would be the week of March 29th. So we don't really have control over it. There's not enough for people to pick and choose like what they want. Some providers will have it, some won't. I think I heard somewhere the best vaccine is the one that you can get, and we're still following that. We just don't have the resources to let people decide what vaccine they're going to get. I mean, if you want to decide and choose, you're just going to have to wait longer.
Great. I did share a screen, and then it was flickering, so I turned it off. So the state's website, coronavirus.idaho.gov, has a giant graphic on there that says "Sign up now for your COVID-19 vaccine pre-registration system." So that's what Logan was speaking to sort of get on the waiting list. That then providers who have vaccine will go to that list and pull names as they have appointments available. Correct? Then you also have some providers who are still taking direct appointments, or perhaps even maintaining their own wait list as they await vaccine. And then that's also true for St. Luke's as well, which I believe yesterday slightly modified its system, where previously it was get in your medical record and sign up for an available appointment. And now St. Luke's is sort of maintaining a wait list as well. Is that correct, Dr. Kern?
Yeah, St. Luke's, in parallel to the state developing their system, has also developed essentially a waitlist system. We are encouraging people maybe not to sign up on both waiting lists. The best way for St. Luke's, if you can navigate it and make it happen, is to register through your MyChart function. But we do now have a wait list within St. Luke's too, which would only go within St. Luke's. And there's some work going on to resolve, whether the two lists can interact with each other and those kinds of things. But for now, they are in parallel and not overlapping systems.
And then I do know as these new systems roll out, they tend to be a little clunky at the beginning, but they do have some great benefits. So for example, I did hear yesterday the state's pre-registration system, once you've had a vaccine and you're entered into the IRIS system that's tracking who has the vaccinations, that's scrubbing against that list. So it's taking names off the wait list who have been vaccinated. So I think there are some advantages to that, but we appreciate that this can be complicated. And frankly, we sort of had plans that this conversation today was going to be primarily about the group 2.3, ag workers, manufacturers, grocery store, and then yesterday this other group, group 3, sort of advanced in the process. So we're navigating this a bit too, but appreciate everyone's patience. There's a question in the chat. A person who's having surgery in a couple weeks, is it safe to get immunized before or after a same-day joint surgery? Oh, you're muted, Dr. Kern.
I have to pay money to our foundation. We have a rule within St. Luke's that if you talk while on mute, you have to go and pay money. I'll add that to the list. That's a complicated question. It depends a little bit on whether or not you would be able to finish your vaccine before the surgery day, meaning if you had a 2-part series and the surgery was going to be in between, that might not be the best timing. But if you were able to get both shots done and have some period of time, probably a week or 2 weeks or more before the surgery, that would probably be the best thing. But it may be worth touching bases with your surgeon's office or your primary care doctor, because again, I hesitate to weigh in too much on the particulars of one person's medical situation, because there may be other factors that your doctors might be taking into account.
We had another question come in by email earlier. How can you tell if the COVID vaccine has taken effect in your body? Is there a blood test of some sort?
New system, blue means I can talk. There is not a blood test that would be able to tell you if it had worked. The reality is that with the Pfizer or Moderna vaccine, there's a better than 95% chance that a week or two after you had the second shot that it's working. So the probability that you're protected is very high, but there is no way to test it to assure that you were protected.
Great. We also had a couple of questions come in that I think were a little bit more specific to treatment for those who have COVID and symptoms. So one was related to a study regarding a home treatment that might be effective that had a lengthy bunch of information. And so maybe start there, Dr. Kern.
Yeah, I saw that question as well. There was a treatment using several medications and then even some zinc and supplemental vitamin D and vitamin C. The reality is that while one study was published advocating for that, there is not good data to say that it works. If somebody came to my office and said, should I take some extra vitamin D and C if I got COVID, I would say, yeah, I mean, that's probably fine. But the cautionary tale is some of our studies on steroids as an example for the treatment of COVID. What we found is that for very sick patients in the hospital, steroids work incredibly well. In fact, it's the mainstay of treatment for hospitalized patients and lowers mortality, meaning death rate, and gets you better faster. But for outpatients who are less sick, it actually made you more sick and potentially put you in the hospital. So I think sometimes there is this sense that here's a good idea, we should do something. And in medicine, we're frequently like, well, something is not always harmless. And, there are interventions, vitamin C and vitamin D are unlikely to cause harm. And that's where, I might say to the patient, yeah, if you feel like that's going to benefit you, that might be. But some of the other treatments, which are less proven and potentially have risk or side effect, I think we have to be cautious until there's better information. Something isn't always better than nothing when it comes to treating infections or any kind of disease. And I think that's important for people that are following this real time to understand. And, this has been one of the complexities of this whole pandemic is this is probably the most publicly that science has played out in the history of the world, right? So we've never had so much scrutiny on real-time science being developed and adjustments in recommendations and guidelines based on new information. And that actually, I'm pivoting now to answering this other question about intubation. The same email thread had a question about intubation causing damage that can lead to death, but giving people oxygen can help with the respiratory issues. So this is a great example, and will highlight where I was kind of headed about the complexity of talking about this pandemic in the way that the science has played out so publicly. When the virus was first identified in China and they were having really a horrific, first experience with it and a lot of dying, their initial data seemed to suggest that early intubation, meaning as soon as somebody was moderately ill or having a little bit of oxygen trouble, putting them on a breathing machine, putting a breathing tube into their lungs was beneficial. So when we first started treating it in the United States, that was the best data that we have, and we were being reasonably aggressive with intubation. And then fast forward even relatively quickly, within a couple of weeks, that started to not seem like the right thing. In fact, the data seemed to be suggesting the United States the opposite. And now we avoid intubation at all costs. The pendulum swung all the way the other way as we got more and more information. Thousands or hundreds of thousands of hospitalizations in the United States gave us a large pool of people to sort of analyze what was working and what wasn't working. And now intubation is dead wrong early in the treatment course for somebody that needs to be in the hospital. So hydroxychloroquine is another one where it played out so publicly. I see the question from Martin there in the chat. Initially, the question had been, well, maybe hydroxychloroquine will work. There was one study that was pretty poorly designed that seemed to suggest that it helped, and then a bunch of much better designed studies that suggested it didn't work. But in the meantime, it had gotten so publicly talked about and I'll dare say even almost politicized, that then as the data started to suggest that hydroxychloroquine didn't work, then people didn't believe the science because it had gotten so polarized, if you will. And that's been a very complex thing. Masking is the same thing. Our original studies going back pre-COVID would have suggested that masking maybe wouldn't have helped. And then it is unequivocally true now that masking helps prevent the spread of the virus. That's a change in our scientific understanding because this virus, first of all, really does behave in different ways than any other virus we've known. In fact, Fauci himself was originally heard saying, there's no way that this virus could spread in asymptomatic individuals because we had literally never seen a virus that did widespread spreading in asymptomatic individuals. And it's very clear that this virus, in fact, does spread very aggressively the day before you're sick. And so, again, people have heard those things and taken it as they don't know what they're doing, or they're always changing, or they're waffling, or it's politics. But the reality is you just have to follow where the data goes. And sometimes that takes you away from what our previously held notions about treatment or infection would have been. And that's happened quite a bit in this pandemic. It's been very interesting to watch play out.
So I think a couple of questions that have come in that sort of tie together. The first is, how long is the vaccine effective? And the second question is, would there be an anticipation that this is like an annual flu shot, that there would be an annual COVID booster?
Yeah, the answer to both of those is we don't know yet. I do think that there is reason to believe that this vaccine will be more effective than once a year. But again, back to what I was just saying, the vaccine has only been out or being studied for about 6 months now. So we really don't have that long-term information to know, are you protected for a long period of time? And so will we need it next fall, next winter? Hard to say, don't know. we have seen, and this is, again, another complexity about this virus, places in the world that had really massive outbreaks in March and then really massive outbreaks again in the fall. So this would have been like Brazil being the easiest example. They had unbelievably high infection rates in March, like pushing 60% in many places. The death rate was horrific. And then it started all over again 6 months later. And we have not seen that same degree of reinfectivity in other parts of the world. So a lot of research going into why they had so much reinfection. There may be features to people who live in Brazil's immune systems not being geared up to make the right kind of immunity to this virus. There are other factors like your probability of having been exposed to parasites in your life, or other infections like the bacteria that causes stomach ulcers, H. pylori. If you have widespread H. pylori, maybe that affects your immune system in some way. Those are just some hypotheses of why certain populations seem to have had reinfection at higher rates than other populations.
Logan, I'm going to jump back to you and talk a little bit again about the eligibility. So we had a couple of questions that had come in advance of people, we care for an 84-year-old mother-in-law who's been immunized. She's concerned that they haven't. One's 57, one's 64, one's diabetic, may have additional health issues. So I'm going to go ahead and put the slides back up here of the CVAC guidance for eligibility. So here's group 2 that we've been talking about. So 65 and older has been eligible. You mentioned earlier about half the folks in our region who meet that criteria have received at least maybe one vaccination, if not fully vaccinated. Then we're talking about 2.3. So this deals with homeless, food and ag workers, National Guard, another subset of utility workers, manufacturing, public transit, postal service, and flight crews. So that's maybe from the employer perspective, those are the folks who are sort of next up in the queue. But when I jump to this slide, also on that March 15th, we have this age 55 to 64 with at least one medical condition. Yeah,
so I guess the example you gave in the email, the 55 to 64, if you have a medical condition that puts you at greater risk, which there's a host of them listed on the CDC website, but most people, they kind of know what they are: diabetes, obesity, lung diseases, things like that. That puts you in the open group on Monday, but then the very next Monday, anybody, the healthiest of that age group can also get a vaccine somewhere. That again, the issue we have is, yes, the door is open, but there's a long line. And really, when we open these groups up, and I think I said this before, all it does is give you permission to get in line. And we want people to get in line. We want them to register. And I believe that on the state's pre-registration tool, people in these groups can go ahead and get on. The providers just can't access them yet to pull them down. So, the person who wrote the email that takes care of their parent that's, has diabetes and whatnot, that person can get on a list right now. And there's nothing stopping them from doing that. So, and then by the time we get to, like I said, 3.4 and we're 45 and above, we're really going to be, have a bubble. Hopefully the vaccine supply starts coming in like they're predicting. And so we'll be able to get through them a lot sooner and just keep going from there. And then I think the general population 16 above will be shortly thereafter. There's been some talk, but I don't know how much they're really serious about just opening it up to everybody. I know Alaska did that this week because of these same reasons. Just it's too hard to tier everybody. Let's just start getting people on lists and getting rid of the vaccine and getting it in people's arms. So I don't know if Idaho is anywhere near that, but Same time, I didn't know we were going to open this group until yesterday, and so next week it could completely change, and we could be giving shots to 16-year-olds. Who knows?
I think to that point too of sort of supply and demand. So the supply, while it's been improving, still has been a little clunky off and on. We had national weather issues a few weeks ago that disrupted distribution across states. There's been some debate about how's the math done to determine how much does Idaho get based on population when we have the second highest under 18 population in the state. They're not going to be in the mix anyway, some of those kinds of issues. But as that vaccine availability improves, one question that I've heard people ask is, well, why aren't we having a mass vaccination clinic, at the football field on Saturdays? That has to do with supply, right? Because we're not getting 10,000 doses in a week, but all of a sudden you say, come one, come all.
Right. So all the providers that we're pushing vaccine out to are able to get rid of all their vaccine in their normal clinics, maybe an extra one here and there, but they're not at the end of the week sitting with 500 or 1,000 doses that are like, oh, we need to get this out, and let's tomorrow go to the football field and invite people and we'll get it out. No, most of the providers are calling us on Thursday and saying, do you have any more? Do you have any more? And that's really why. And once these shipments start to build and we start to see maybe a slower demand amongst a group, we may be able to say, hey, we're going to set up shop here. Come here if you want a vaccine, and do these major clinics. And another reason is that those big clinics do utilize a tremendous amount of resources from whatever provider or providers are putting them on. And so it really has to be worth the while, and you need the vaccine and to really push those out. If St. Luke's can do 1,000 vaccines in a week in their normal workflow, that's much easier than moving everybody to a different location and doing the same amount.
Yeah, and I mean, one other thing I'll put out there is, again, getting people clustered together isn't necessarily beneficial when you can do it in smaller bunches where there's less probability of exposing others to the virus and those kinds of things. So again, on one level, yeah, it makes sense to try to do a larger event and get tons of people done. But to what Logan just said, if we can get everybody done at your local pharmacy where there's not likely to be as many people or less risk of exposure, that's better.
So I think we're getting close to a time to maybe wrap up here. If anybody has any last minute questions, feel free to throw them in the chat, but maybe to just summarize a little bit here. So the number of cases is looking much better in our community. However, that doesn't mean the pandemic's over and go back to life as normal. Still using the mitigation that we've been hearing and talking about for 12 months now of wear a mask, keep your distance, wash your hands, stay home if you're sick, those kinds of things. New mitigation now with vaccine availability, because again, it's not a silver bullet to everything. It's just another part of the mitigation here. Number of people who are becoming eligible is growing, utilizing perhaps a more streamlined process for getting on a wait list there with the state's wait list, which are the pre-registration system, which again is available at coronavirus.idaho.gov. You can access it through a whole bunch of other channels too, but that's where it's sort of front and center. Or reaching out to individual providers, and the health district has that list on their website of those in our 8 counties here who are providing vaccination. And then also St. Luke's and certainly other healthcare providers as well, having their own systems available. So if you're in one of those upcoming eligible groups, with many of these, you can get on there now and sort of get on the wait list, even though you may not get a call till after Monday. But probably important to set expectations too, that just because Monday is suddenly food processors and manufacturers and all these people doesn't mean you're going to get a phone call next week for an appointment. Is that a fair summary of kind of what we've touched on here?
Yeah, sounds good. And I think that last point is probably one that I should have made a little more too. And the fact that unfortunately in every group, somebody gets to go first and somebody has to go last. And so everyone's going to be jockeying for position to get in first or get their employees in first. And I understand that from a business standpoint. But somebody's probably going to have their entire staff vaccinated the first part of April, and some other company might be May 1st before they're getting people done. So it's just continue to be patient, and we're, just know that everyone's working hard to get these vaccines out.
Well, again, Logan and Dr. Kern, appreciate both of you taking the time to be with us today, and for everybody who joined. We will anticipate potentially doing future webinars like this when there is new information to share. We don't want to have webinars for the sake of having webinars, but as we can try to provide greater information and help people navigate this ongoing issue and some of the challenges around it, we're happy to do that. So again, thanks everyone for being here. We will be getting this posted online. So if you have others you want to share it with, you can let people know about that. We'll also be having a Spanish translation completed so that we can try to reach some of our Spanish-speaking population throughout the region as well. Question there from Susan: how can we learn about future webinars? So we're trying our best to publicize it wherever we can find. So local media had advance notice of it this time. Through the chamber, we're promoting that to our business community. And I know all of our partners have shared it on their Facebook pages and things like that. So we're trying to get about a week's notice out on those. This one was a little quicker because there were so many rapid changes that happened. But I would just encourage you to keep an eye out on your local media, and we'll try to spread the word as best we can. So again, thanks everyone for being here. And with that, have a great rest of your day.
Thanks, Shawn. Thanks, Logan. See you guys.
Yep. Thank you, guys.
Bye.